Hey y'all, this is Dr. Carmen Corder with thedoctornurse.com, and I'm back here again this week with my husband Michael. This week we are going to do an objective assessment. So your objective data are the observations that you are making as the nurse, okay? What you're listening to, what you're hearing, what you're feeling, what you're seeing. Those are all objective assessment data, okay? Whereas last week, the subjective data are all the questions that you ask the patient. So the first tip that I want to give you when you go to do your head to toe assessment is you've got to get a system in place when you're learning all these different assessments that you're going to have to make. My suggestion is to start with everything that pertains to the neuro assessment. Then move on to everything that pertains to the cardiovascular assessment. So go system by system. Don't try to get your systems mixed up or you will forget something. All right. So neuro is first. We'll start with the head. We'll start with neuro. And with neuro, you're going to be checking the level of consciousness, which is how awake the patient is. You're also going to be checking mental status, which is are they oriented or confused. So you can have a patient that's awake but confused, right? You're also going to be checking PERLA, so pupils equal, round, reactive to light and accommodation, and you have to have your pen light. Do not forget to bring your pen light to your checkoffs and to clinical, all right? And I have my pen light here today. I have a 5-year-old because I can't find my pen light, so this is mine. So the next thing after PERLA, you're going to do EOMs, or extraocular movements. That's going to be your 6 cardinal fields of gaze. Those are either intact or not intact. You want to document pupil size. I find that most patients' pupils are 2, about a 2, all right? Some may vary. You know, if you have somebody that has very large pupils, a lot of times that's because of atropine. So just keep that in mind. And then finally, you're going to check their grip strength and leg strength. And this is graded from 1+ to 5+. Now, we're not checking to see how strong your patient is. I don't care if they're Hercules. What I'm checking for is, are their grips equal on both sides, right? Because that is a sign of a stroke if one side is stronger than the other side. All right, so I'm going to go ahead and perform the neuro assessment. And remember, I'm going to do all things neuro before I move on to cardiovascular. All right, so we're going to assess level of consciousness first. Michael is very awake, very alert. Next is mental status. So these are the questions that you're going to ask about orientation to person, place, time, and situation. So can you tell me your name?
Michael.
All right. Can you tell me the month and year?
September 2018.
Okay. Can you tell me where you are right now?
Jackson, Tennessee.
All right. And in the hospital, the orientation to situation is you would ask your patient what brought you to the hospital, because they may be able to tell you, yeah, I'm at Jackson General, or yeah, I'm at, wherever, but they may not know why or remember what brought them to the hospital, so they wouldn't be oriented to situation. All right, so that's level of consciousness, that's mental status. The next thing is PERLA. So you would take your pen light and you would have your patient look at you, and you would tell your patient, look directly at my nose, all right? And you would take your pen light and you would shine, you would come in from the side and shine and make sure that pupil is constricting, and come in from the other side and shine the light and make sure that pupil is constricting. At this time, you're also going to look at the pupils for their size, all right? So that's reactive to light, okay? They're equally constricting to that light, and having the patient look at your nose protects them from that light that's shining in their eyes. And then accommodation is when we have them focus on an object close up, then we move it back, all right? And as we move the object back, their pupils are going to dilate. As we move it closer, you're going to see those pupils constrict. So that is reactive to accommodation. The next thing we're going to check are the EOMs, or the extraocular movements. Now, I can tell you that Michael's are intact, he's been looking around the room. He can't keep his attention focused on anything. He's looking around the room, you know, so that tells me that yes, you know, the cranial nerves that have to do with EOMs are intact, but for your checkoffs, you're still going to need to do those 6 cardinal fields of gaze. All right, so you would have your patient follow your pen up, down, and then to the sides, and then diagonal, down, and then diagonal. All right, and if they can follow your pen without moving their head, then their EOMs would be documented as intact. All right, and so the next part, we're not going to check every single cranial nerve in just our head to toe assessment, but the next part is going to be grips and legs. So I would have my patient squeeze my fingers, all right, and again, I'm just assessing for equality. And then I would also, I'm not going to ask him to, but I would also then have my patient push against my hands with their feet, because you know certain strokes can affect arms but not affect the legs, and then vice versa. Some strokes can affect legs but not arms. So you're looking for equality. All right, so the next part is going to be the cardiovascular assessment. What we're assessing for here, we're listening to the heart sounds. We're feeling for peripheral pulses. Excuse me. We are feeling skin temperature and moisture. We're inspecting the skin for skin color, because somebody that's gray is probably not in good shape cardiac wise. And then we're also going to check capillary refill time, which we want it to be less than 3 seconds. All right, so I'm just going to show you where to put the stethoscope. Now, you know the 5 places that you're listening are, your acronym is APE to man, right? Aortic, pulmonic, Erb's point, tricuspid, and mitral. And a little tip that I never really knew this in nursing school because nobody told me, but where you're putting your stethoscope is actually where that particular valve sends the blood. So when I put my stethoscope here, I'm listening to the aortic valve here on the right side. If you could lean back, maybe if I could adjust this. Yeah, there we go.
You just put it on my chest.
Yeah. So I would listen right about here for the aortic valve. That's on the right side. That's where the aortic valve sends the blood. Pulmonic valve here. Erb's point about right here. Tricuspid is right underneath. And then the mitral valve right around here. All right. So now if this was a female, you would have to be moving some tissue up out of the way, and you're just going to have to get comfortable with that. Okay. So those are the 5 places. All right. Aortic, pulmonic, Erb's, tricuspid, mitral. And that mitral valve, that is your point of maximal impulse. That is where you would listen for your apical pulse. That's another part of the assessment that you would need to do. So the next part, and to document that, you would just document S1 and S2 noted without murmur, okay, if you don't hear a murmur. The next part are peripheral pulses, all right? And so peripheral pulses are assessed. We're going to assess radial pulses, and they're usually graded from 1 to 4. 1 is kind of weak and thready. A 4 is very, very bounding. Most people are going to have about a 2+ for their radial pulses, but their pedal pulses are usually going to be a little bit weaker, just because circulation, especially in our older patients, is not going to be as good down to the distal extremities. All right. So where you would feel for the pedal pulses, so you're going to feel for your pedal pulse, and it's usually right around the top of the bone here on the top of the foot is where you're going to best feel the pedal pulse. You're going to feel around and feel around. The next step, if you cannot feel the pedal pulse, is you're going to have to try to feel for the posterior tibial pulse, which is going to be here on the inner aspect of the ankle, okay? And if you cannot feel a posterior tibial pulse, then you're going to have to go get a Doppler, okay? Because that means that there's some sort of interference with circulation down to the feet, okay? So first feel for a pedal. If you can't feel that, then feel for your posterior tib. Can't feel that, then you need to go get the Doppler. Pulses again are graded from 1 to 4+. Also, while I'm down feeling for pulses, I'm feeling and checking for peripheral edema, okay? Because that's where you're going to find it, is around the ankle area, okay? So then, the final part of the assessment, which I've already kind of been doing because I've been feeling for pulses, I've been feeling radial pulses, I've been noticing his skin temperature, and his skin is warm and it's dry. If you have somebody whose skin is cool and clammy, that's a cardiac red flag, right? And then finally, you want to check capillary refill time, all right? So you would, I'm going to have you turn. So you would just depress.
Like that.
Yeah, depress the finger, and then you're just watching for that color to return in less than 3 seconds, all right? So you would do that actually on the fingers and then on the toes. Now, most programs don't ask you to do Homan sign anymore because it's really not that effective. So that's why I'm not gonna show you Homan sign. All right, so moving on to the respiratory assessment. So the biggest part of the respiratory assessment is obviously listening to lung sounds. Now, this can be very challenging if you have a patient that's so sick that they can't lean up where you can listen to their back, because it's very important that you're able to listen to their back, because you'll often catch some crackles or something in those posterior lobes that you won't hear in the anterior. All right, so one pointer that you need to point out when you're listening to lungs, make sure that you're comparing side to side. Do not use your scope and listen here, then go down, down, down. You're going side to side. All right, so let me show you where to put your scope. And I always, when I'm listening to breath sounds, I ask my patient to breathe through their mouth, because that's going to amplify the sound. All right, so I'm just going to show you where to put the scope. I'm not really going to have him breathe or deep breathe or anything like that. But you would start kind of high up here. Side to side. Okay, now I'm going to do the anterior part. If you can turn back around this way for me. And I'm just going to show you again. So you would start kind of up here above . All right, and your program may have you listen to lateral lobes also, and just remember that the right side has 3 lobes. So you would listen here and then move to the front and then down. Your left side only has 2 lobes, so it's basically just here and here, right, if you're listening. The other parts of the respiratory assessment, obviously you're going to count respirations. You are observing if they are having any distress, using any accessory muscles. Obviously, he's not in any distress. I can tell that his respirations are not labored. So you would document his respirations as regular and unlabored. Document breath sounds. You want to address all the lobes when you're documenting breath sounds. Okay, so they may be clear as a bell, up here, but then you may hear some crackles in the bases. All right, make sure you address that in your documentation. You also want to make sure that you take note of how much and what type of oxygen device your patient is on. All right, so standard 2 liters binasal cannula. All right, obviously Michael is on room air. Okay, so that kind of concludes the respiratory assessment. The next assessment is going to be the GI, and the GI assessment is very special in that you're inspecting first, but then you're going to auscultate and then palpate. All right, So you would auscultate in all 4 quadrants. Let me pull the... All right, you would auscultate in all 4 quadrants. All right, 2, 3, 4. So you would auscultate there. Your bowel sounds are going to be documented as active, hyperactive, or hypoactive in all 4 quadrants. Then you would palpate, all right, and you would palpate and document any tenderness. So you would document if the GI assessment was perfect, you would document bowel sounds active in all 4 quadrants, abdomen soft and non-tender to palpation. And before I would have done any of that, I would have kind of observed his abdomen and make sure there's no visible peristalsis. In other words, his abdomen's not kind of moving on its own, all right? So that would denote some sort of hyperactive process, maybe a bowel obstruction or something like that. The next part is the genitourinary assessment. The only objective parts to this really that you're going to be doing, you would probably palpate for any bladder distension if your patient has had trouble voiding. If your patient has a Foley catheter, you would observe the urine in the Foley catheter and you would need to document the color and the character. So is it clear yellow? Is it amber and cloudy? All right, so document both aspects of the urine. Document if your patient uses a urinal, that they use the urinal, but there was no urine in the urinal at the time that you did the assessment, but you will continue to monitor. And as soon as that patient does void in the urinal, then you would document the color and the character of the urine at that time. Another thing about Foley catheters, make sure that you document that the urine is draining to the bedside bag, all right? Because you want to make sure that you've checked and there's no urine leaking out of the bedside bag. Finally, you're going to check the IV site. And the things that I have my students document about the IV site is that it has no redness, edema, or pain at the site, all right? That covers all the bases. There's no infection, there's no infiltration, that IV is working properly. You document what type of IV fluids are infusing and that they are infusing without problems. The final things that you're going to document and wrap up with are your quick safety assessments. The bed is in the lowest locked position. The side rails are up ×2 or ×3. The call light is in reach. The patient denies pain or needs. Make sure you use that verbiage, because when you say that they deny pain or any needs, that implies that you asked. All right. And then finally, if they have any fall precautions, that the bed alarm is on and that their bracelet is on. And that kind of wraps up the objective part of the head to toe assessment. I hope y'all have found this helpful. Thank you so much for watching. If you are watching this from YouTube, head over to thedoctornurse.com. There are so many other resources. There are several blog posts all covering different parts of the head to toe assessment. So again, thank you for watching. Thank you for being my patient again this week, Michael.
You're welcome.
And I hope you guys have a wonderful week, and I hope to hear and see from you guys very soon.
Look, wait. And so this dame come into my office. She had some problems, but I could see when she come into the Mike Quarter Detective Agency. You know they always got that.